My name is Gudrun Burnett, but everyone calls me Goody, and I have the absolute privilege of chairing this Pathfinder event this morning in conjunction with our partners, which is Safe Lives, Iris, Ava, Imcan. This project has been funded by the Department for Culture, Media, Sport and Department of Health and Social Care. And we're really proud to share with you the findings and some of the best practice that's come out of this amazing project. I've been the new CEO of Standing Together for only 4 months, so I'm 4 months in. And this is the first event I've actually chaired in my new role. And obviously I've never done it via Zoom before, so bear with me, I'm sure we'll have some technical glitches at some point. We've got an amazing array of speakers today, which we're really, really excited about. In terms of domestic abuse and health have got such a vital role in responding to domestic abuse. We know from lots of research that health professionals are in an ideal place to kind of identify and respond to domestic abuse, and this project was the first, it's kind of been the first, I guess, partnership to try and think about how we can do like whole systems change in the health setting in a number of pilot sites across the UK. I just want to do a shout out to the amazing team. So in the background you won't see them today, but Vanya and Caitlin and Miranda, who have worked tirelessly to put this together today. So thank you so much. I know that Caitlin's put the agenda in the chat, so you can access it there. This whole thing is going to be about 2 hours long. We've got a number of, like I say, amazing speakers. We don't actually have time for Q&A at the end because the amount of panels, but what we do have is the Q&A function in the bottom. So if you've got a question, please just put it into the Q&A, and what will happen is that Caitlin and Vanya in the background will be trying to answer those in real time in terms of just responding to you directly on that. If there are any questions that we don't get to, we will basically try and come back to you afterwards, and we're recording this entire webinar. We'll have all of the questions, so we'll try and come back to you for that. What else was I going to say? In terms of the agenda, we've got, we're going to hear from the Minister, who couldn't make it in person today, but has sent us a video. We've got Nicole Jacobs, the Domestic Abuse Commissioner. We've got GJ, who's one of our independent evaluators. I could go through them all. We've got an amazing expert by experience, Alicia, who I can't wait to hear from. So we've got a lot of stuff for you to hear. I'm just trying to think if there's anything more I need to say apart from maybe something together about something about tweeting throughout the day. So if you are a keen tweeter, anyone that knows me will know that I am. I think it's a really good way of pushing out messages in terms of what we can do. The hashtag for today will be whole health and a hashtag Pathfinder. And obviously, please make sure that you link in Standing Together, Imcan, Safe Lives, Ava and Iris as well in terms of that. So I think that is everything that I want to say, because I'm going to let you hear from the absolute experts in this. The first thing that we're going to have actually is the Minister has sent us, Nadine Dorries has sent us a video. So I'm just going to ask Caitlin if she wouldn't mind sharing that with you all now.
Good morning. I am so sorry that I am unable to join you in person, but I am delighted to be able to open the event, which both celebrates the achievements of the Pathfinder project and shares the valuable learning from it. I'm glad we were able to virtually bring together so many partners from across healthcare, the voluntary sector and further afield. I'd like to thank the Pathfinder Consortium, Standing Together, Safe Lives, Iris, Imcan and Against Violence and Abuse. They have all worked tirelessly to help deliver the project and to make it such a success. And my thanks to Standing Together for leading and for organising this event today. My thanks to the survivors who shared their experience also to help shape and improve the support from healthcare services. I know how difficult sharing personal experiences can be. It requires real courage, and your voice is crucial to help our understanding, and it must be listened to. Domestic abuse is a terrible crime, and it can have a devastating impact on victims, survivors, as well as their children. The government is clear that there is no excuse for abuse. Tackling domestic abuse and supporting victims, survivors, and their children is a key priority for the government now more than ever. The Domestic Abuse Bill and wider action plan will help to protect and support victims and their children. I attended the Prime Minister's Hidden Harms Summit, which focused on how to tackle domestic abuse and other hidden harms, which may have been affected by the coronavirus lockdown. It was clear throughout these discussions that we need to work together across sectors to succeed. It is clear that the healthcare services must identify risks and harm and enable victims and survivors to come forward and provide timely, integrated care and support. As Minister for Mental Health, I am acutely aware of the impact of domestic abuse on mental health, and it's essential that survivors get the mental health care and support they need, and that services are trauma-informed. During COVID-19, the NHS has been working around the clock to support people with mental health needs. And I recognise the huge efforts to keep a range of vital services across the healthcare sector open to support survivors. People up and down the country have made an extraordinary sacrifice as the government has taken unprecedented steps to control the virus. But we recognise that the emergency measures to control a pandemic may place some people into an even more vulnerable, isolated and dangerous situation. We have all heard how domestic abuse helplines have seen an increase in the number of calls, as well as the complexity of the situations, and I'm deeply sad to think of what victims and survivors and their families have gone through during this time. But I also want to reflect on how important it is that so many people are seeking support and not suffering in silence. The Pathfinder event is therefore timelier than ever to share good practice and ensure we can support those impacted by domestic abuse. It is crucial that victims, survivors and their children receive the care and support that is person-centred and recognises their specific circumstances and challenges. And we must therefore listen to the voices of survivors and shape our response to the delivery of services. We must recognise that domestic abuse is experienced in different ways, and therefore support may need to be tailored to individual circumstances. And we need to be able to respond to all forms of domestic abuse. The Pathfinder project provides a roadmap to shape how we can best support all victims and survivors of domestic abuse in the healthcare services. This whole system approach is crucial to make sure that whichever healthcare service someone turns to, support is there and available. Pathfinder has given us a model for our response to domestic abuse in healthcare. It is a model for integrated, joined up and trauma-informed care and support, with healthcare settings and the voluntary sector working together. Once again, I extend my thanks to all those involved in the project. Working together, we can help to ensure no one suffers from domestic abuse, and that we provide the best possible support in the NHS for victims, survivors and their children. Thank you.
So that obviously was really powerful, and it's great to have the Minister support us as a consortium. Obviously there is so much more long-term work that needs to be done in this area in terms of whole systems and thinking about systematic change and how we can improve the whole healthcare system in its response to domestic abuse. Now I'm really pleased to introduce Alicia. who is our expert by experience. Alicia, I'm going to
Hi
stay
there.
on the screen with you, so you are talking directly to me, but I will put myself on mute, okay?
Okay, no problem.
Thank you
Okay,
so much for being here.
no problem. Hi everyone, and I apologise that I'm on my phone because my internet stopped working just before this meeting. Okay, so I'm a doctor, a linguist, a teacher, a dancer, ran my own business successfully for 5 years, a caring and compassionate friend, and also a survivor of domestic abuse. I spent 7 years in what I now understand was a coercive, controlling, and physically and sexually relationship with a man who convinced everyone around him, including my own family, that he was a calm, intelligent person who loved me. When I first tried to leave him, he was physically violent, smashed up our flat, dragged me out into the street, and took my bag as I eventually managed to escape his grip and run to hide in the coffee shop. He later convinced my family, and eventually myself, that this was all my fault, and after a year of stalking and harassment, even moving to a new city to follow me, I was persuaded by all parties to return to him. Nothing changed, obviously, and the second time I tried to leave resulted in serious sexual violence and rape. Having been worn down for so long, it never occurred to me that I wasn't the one at fault. Hearing that sentence now sends chills down my spine, but that was the mental state he had reduced me to. But I thought I was strong. I just kept going in life, apparently successfully, until, inevitably perhaps, I developed severe depression and was referred eventually by my GP to counselling and later secondary mental health services. Whilst waiting for over a year for therapy, having had to recount my life story several times to various mental health professionals who never asked further questions about my traumatic relationship, often appearing uncomfortable in asking questions, and thus confirming my own sense of shame and inclination to disregard the impact of my past, I discovered he had raped another woman who was now going public with her story, having recently won a legal battle for non-disclosure agreements with her workplace, and that he had stayed in contact with my family all this time without my knowledge. I began to develop nightmares, panic attacks, hypervigilance, overwhelming guilt, and serious suicidal thoughts. My GP was kind and supportive, but didn't know what to do. The psychiatrist I was under asked me why I hadn't reported him to the police previously, thus increasing my own guilt, and advised me that I shouldn't talk or think about it, as I was, to quote, giving myself a bit of PTSD, and to increase my medication in the meantime. In desperation and genuine fear that he knew where I lived, and occasionally still emailed me every few years out of the blue saying we should meet, to which I had never replied, a friend put me in contact with an incredible charity, Women and Girls Network, where I was allocated an independent sexual violence advocate who changed my life. She liaised with my GP, with the press, advised me about my possible court options, and referred me to a support group in which I learned skills to help understand what I had experienced, what forms of abuse looked like, what giving consent actually should be, my right to set clear personal boundaries, and how to manage the symptoms of PTSD with other women who had survived similar experiences of physical and sexual violence. I can say without any doubt in my mind that she quite literally saved my life. I felt seen, heard, validated for the first time. 4 years on, I'm still waiting for NHS therapy, having been deemed in need of something more, but undefined as there was no clear service for my needs, no clear pathway or diagnosis I could neatly be fitted into, a difficult case. My experience within the NHS has been varied, but very focused on what is wrong with me, and often disregarding the huge impact that domestic violence can have in terms of trauma, what felt like almost being silenced again, and sadly often judged in ways that mirrored the words of my abusive partner. The unhelpful phrases of, "surely you should have known better," still ring in my ears. Within the charitable sector, luckily, I was listened to and my experiences validated. The power of being asked, "what bad experience has happened to you?" rather than "what is wrong with you?" is possibly the most important message I can share with you all here today. To feel heard, to be given a voice, is both empowering and healing, and has led to me being here today so that I can hopefully contribute to a better understanding and treatment experience for any survivor of domestic abuse accessing NHS services at every stage of their recovery journey. I believe that with better training throughout services at every level and tools that enable professionals to ask appropriate questions without feeling uncertain will allow many more people to both recognise their own experiences and help guide them to care pathways that meet their specific needs and give them the support they fully deserve. Thank you.
Alicia, thank you so much for that. It was so powerful, and I appreciate you so much, and I don't really know how anyone's going to follow that, because you just said it all in 5 minutes in terms of the importance of this event, and putting yourself out there and sharing that with so many people is an incredibly brave thing to do, and we're really proud and we're really humbled that you were able to take part in this. So thank you from all of us, all the partners.
Thank you for giving me the chance.
All right, take care.
Bye.
So next we're going to hear, this is it, I've got all my notes on my iPad. Next we're going to hear from Nicole Jacobs. She doesn't really need much introduction. She is the new Designate Domestic Abuse Commissioner and obviously previous CEO of Standing Together, and has been an integral part of this whole project from when it started 3 years ago. So I'm really excited to have her here and also to get her input. Nicole, hiya.
Hi, thank you. It's great to see you, Goody. And Alicia, I really appreciate you starting off our day with those messages. And I agree with Goody. There's no doubt that you've said it all, essentially, already. But I think hopefully throughout the day, some of us will be able to contribute, how, and a little bit more of the how do we achieve what you really can see, which is that really person-centered approach, and the integrating within health systems, the kind of really systemic change that we need. So I just want to say thank you so much. And thanks, Goody, for having me, and you're doing a great job at Standing Together. So if anyone here, and surely there'll be lots of participants who've never met me before, as Goody said, I'm the former Chief Executive of Standing Together, and I was appointed in late September as the Domestic Abuse Commissioner, and I'll come back to that a little bit later. But I just wanted to explain to you why I think Pathfinder is so important, and a little bit of where it came from my perspective. I was thinking back yesterday about this. It would have been about year 2000, of 20 years ago, so I'm dating myself already. I would have been working for Standing Together. I worked for Standing Together twice. So one time about 20 years ago, and then I came back later, because I so believe in the coordinated community response, which is what Standing Together drives in so many different areas of work. But when I was there the first time, I was a health development worker, and my job was to start to make some inroads and some partnerships with the local A&E and the walk-in centers. And just three kind of images came to my mind when I think about that. The first is my walking into the kind of the staff lounge of the walk-in center for the first time, when they were expecting me to come and talk to them about domestic abuse, and being really nervous as a quite fairly young worker, and wondering how many people would be there. It was lunch, it was busy, and it was completely packed out. I mean, it was standing room only in the staff lounge, and the level of interest in domestic abuse from the staff at this walk-in center was really inspiring to me, and possibly was surprising at the time, but shouldn't have been, because what I learned was that there was huge interest both in the personal experiences and the lives of the people working within health settings, and their own experiences of domestic abuse and wanting to talk about that, and obviously the day-to-day experience they had with patients. The second image that came to mind was being in the A&E. around that same time, and someone at the front desk showing me the kind of tattered binder they used with domestic abuse. So they had a set of resources that they would kind of put into the binder. And again, what that showed me was, number one, they saw domestic abuse all the time. And number two, they were trying. But what I could see immediately was that they were very busy. It was difficult to keep up with the changes in our services locally. And this was 20 years ago when they were much more underdeveloped than they are now. But it was this desire to do something. And then I suppose the third thing, very quickly, is just the look on the faces of my colleagues at Standing Together when I told them that the consultant at the A&E was really on board and wanted us to come in and train, and in fact wanted to join our steering group and actually come to additional meetings outside of his day-to-day work. And they were delighted but shocked. And so I think it just gives us a sense of where we've been. And I just want to recognize for all of the health practitioners on this call how much you have been building practice over time. And that is, to me, the real inspiration of Pathfinder, is to say, we've got to find these areas of excellent practice and join up and help improve in any way we can, and really model what is the health response to domestic abuse. Because as Goody said earlier, and one of you might be thinking, will be thinking, and so what we have to do is raise our ambitions about this issue and make health and the response to domestic abuse and a level of activity across all of those trusts and across the CCG and commissioning and all the moving parts of the health system. Anytime we've talked to health, they will tell us time and time again, please don't treat us as one entity. You know, there's so many levels of decision making. There's so many drives. Worker. Say a health trust on progress.
Oh, Nicole, we're having some connection issues.
Systemic work within the. Just let me know. Is it? Can I?
Yeah, it's just breaking it for the last sort of 4 or 5 minutes, but we're actually running way on time, so it's fine. So don't worry.
I'm sorry. Some of what
I think it just broke up when you started talking about sort of systemic change, CCGs, and then you were talking a little bit more than that, and then it kind of broke up for, I'd say, about 2-3 minutes. So, but you've still got plenty of time. So just back a little bit, and then everyone will hear what you've got to say.
I'll back out. So essentially, it was just to say that the root of Pathfinder, or the real driving force of Pathfinder, is to recognize all of that work that's been done over the years and that desire to change, but to really help articulate the breadth of work when we say health and domestic abuse. You know, that we have to raise our ambitions. So that is mental health trust, acute hospital trust, community-based services. And we don't do that enough. And what we also don't do enough is we don't acknowledge what it means to systemically change, help systemically change, and the partnerships that requires. The more health will do, the more they will say how much they need their community-based partners in specialist domestic abuse services, and vice versa. And we need to understand what's the breadth of work you do within health, within the CCG or acute trust or mental health trust, to really achieve that systemic change. And it's not just co-locating a worker, as good as that can be. It has to be much more systemic than that. And that's why I'm so excited about the toolkit and I'll be sitting back and really taking notes today, because there'll have been so much progress that even I'm not aware of since the time I left Standing Together. So I just wanted to explain from my point of view why I think this is such an important project, and why I think we shouldn't view this as any kind of ending. You know, in my view, the Department of Health, the government should be supporting this rollout of this toolkit, and supporting that kind of the ways that we can systemically change. And we'll hear so much more about that today. I just want to say just a couple of minutes on my role as the Domestic Abuse Commissioner for England and Wales. So I guess my role impacts some of what you're doing in 3 ways. One is about what the minister spoke about cross-government working. So, you know, domestic abuse is the type of issue that runs through the whole of services in community-based and statutory services, and therefore needs to have the same kind of level of coordination in national government. So I was very pleased to hear the minister talk about the Hidden Harm Summit that the Prime Minister hosted recently. And my main argument, or my main input into that summit, was about that need for cross-government working. And I think of the need to integrate health and social care into that work plan as prominently as possible, because as you said earlier, Goody, we will be able to get much more early intervention, much more diverse interventions through health settings, and we all know that. So I will definitely be trying to drive that kind of cross-government working. The second is the domestic abuse bill. So we still have time. Everyone on this call, we've got 306 people I can see right now. If you haven't contacted your MP yet, this is the time. Really and truly, it is the window. The bill is now traveling fairly quickly through the parliamentary process, and we don't have anything in it in relation to health. Probably the best we'll have at this stage is statutory guidance which covers health-related work, and I would hope would definitely include the Pathfinder toolkit. But there's no reason why government couldn't expand its statutory duty for community-based services to include some health work. And I think it is really worth making that point. And particularly if you are a constituent of a Conservative MP, I would really encourage you to try to get in touch and really follow that bill in the next few weeks. And the last I would just say is the mapping. So what the bill does is it gives my office a statutory underpinning to ask for information, and to also an expectation for my office to map what does good look like in any area. And in my mind, that absolutely covers the core specialist domestic abuse services, which which we have, unfortunately, a postcode lottery for in England and Wales at this time. But it also covers the coordinated community response. What is the role of health, housing, all community-based work? And I will include the role of acute hospital trusts, CCGs, mental health trusts, and really model this thinking that has been established in Pathfinder in my mapping. And I suppose my last call for you and plea before I sign off and enjoy the rest of the session is, if you have any ideas about the kinds of things that my office can do in the asking for information, and also thematic reviews and that mapping type work, I would really like to hear from you, because obviously I don't know it all. I really want to know what you think as practitioners would really make the change in the decision making at the highest level of your trust or your CCG or your organization, so that we can make sure that we achieve a much more holistic picture for health. So a huge thank you to the Pathfinder partners. I know probably more than many how hard you've worked, and I'm so proud of what you've done. And I know you've put in just incredible work, and I'm really proud of the health sites, the 8 Pathfinder sites. And I hope that fairly soon, if I haven't visited already, when we have more ability to move around, that I can come and visit some of the Pathfinder sites in person. So thank you, Goody, for having me. And I will now sign off and be listening very intently to the rest of the day. Thank you.
Thank you so much, Nicole. That was fantastic. And even with the technology problems, it was absolutely fine. And you're still actually ahead of time. You're supposed to still got, you still got 5 minutes. So, I mean, you're basically being dreamy right now.
I'll pass that along to other people who can give a lot more.
Thank you so much, Nicole.
Great, thanks.
Cool. Right, so next on the agenda, we've got Rebecca Reynolds, but I think everyone calls her Bex. She is the National Safeguarding Clinical Lead with NHS England and NHS Improvement. We're really pleased to have her with us today. We spoke on Monday, didn't we, Bex? That's the first time we met, so it's lovely to have you. I will let you carry on. Take it away.
Thanks very much, Goody. I'll just wait for my slides to pop up. Marvellous. Thanks, Caitlin. Okay, so good morning, everybody. My name's Bex Reynolds. I'm National Safeguarding Clinical Lead and a midwife working in NHS England and NHS Improvement in the National Safeguarding team. So thanks for inviting me to talk today on such an important initiative. I'm just going to talk a little bit about the NHS as a person, so if you'll bear with me. So I believe that the NHS is uniquely placed to respond and support any victims and survivors of domestic abuse. However, we first have to acknowledge that the 1.5 million people who make up our fabulous NHS are citizens in their own right, and that they themselves may be experiencing or perpetrating abuse. It's estimated that over 50,000 NHS staff, 44,000 female, 6,000 male, will have experienced domestic abuse in the past 12 months alone. I think it's important to consider that the people who make up our NHS require the same compassionate response and support in order for them to provide the best care to our patients. Next slide, please. So we all know that domestic abuse is a public health issue, that living without fear of violence is a fundamental requirement for health and well-being. I think it's probably useful to share some insights we've learned about the domestic abuse situation during the public health emergency that we're currently facing. So we've seen an increase in self-disclosures of honour-based abuse at antenatal appointments. Midwives have shared that partners, family and friends not being present at face-to-face antenatal appointments and postnatal discharges has allowed for a more open conversation about safe relationships and domestic abuse. Designated professionals have shared that there's been an increase in MARAC referrals, so multi-agency risk assessment conferences. And as we entered lockdown, we all heard and saw the sharp increase into calls to support lines for domestic abuse. And the National Crime Agency has recorded an increase in adolescent to parent abuse. Yet, we're still hearing that people are concerned to share information and share data, even during this public health emergency. And we need this data to better understand the scale, to be better able to respond and support anyone affected by domestic abuse and violence. Domestic homicide reviews consistently show that we have a critical role to play in health by intervening earlier, by providing a window of opportunity of support for victims and survivors to disclose. We have to make every contact count. Key to this work is the violence reduction units, and I'll touch on that a little bit later. And as Nicole said, right now we're all eagerly awaiting the domestic abuse bill to become an act of Parliament. But rather than wait, NHS Safeguarding are refreshing our existing domestic abuse and violence plans to ensure we continue to flex and learn about the challenges we faced during COVID-19. So just to give you an example, professionals had raised concerns to the National Safeguarding team regarding how to ask safely about domestic abuse in a virtual space. So much of our work during the peak of lockdown and even now was either by phone or other digital means, and it seems that this is set to continue. Our trusted domestic abuse partners, Safe Lives and IRIS-I, supported by the violence against women and girls sector, including the wonderful Standing Together, rose to the challenge and have produced guidance about asking about domestic abuse safely in a virtual health setting. And if it's not been published today, it will be published imminently, and I'm sure that everybody will be updated on that. Next slide, please. So, in order to better understand the unseen, unheard, unknown, and untold, we need to challenge and change our narrative. Challenge the social norms. So children cannot unsee or unhear violence and abuse. We need to create opportunities to discuss what a healthy relationship looks like at a really young age, when we haven't perhaps had that role modeled for us growing up. We need to challenge our unconscious bias. Professional curiosity is key here to check and challenge behaviours in ourselves and our colleagues. Otherwise, we will continue to see the health inequalities that mean victims and survivors from certain protected characteristics are still less likely to be asked about domestic abuse, believe when they disclose abuse, and offered adequate support to meet their needs. We need to create a common language. We have to use the powerful lived experience narrative, such as Alicia's, to create an inclusive one that speaks to all victims and survivors. Next slide, please. So the government serious violence strategy, published in 2018, represented a real step change in the way that we think and respond to serious violence, establishing a new balance between prevention and law enforcement. The approach to preventing serious violence, however, needs a shift from traditional ways of working to, as we've heard, whole systems approach. It's so important that we recognise and accept the change is complex, really messy, and it takes time, and it needs to be flexible in its approach. So programs of work such as Pathfinder believe that a coordinated and systemic approach lies at the heart of all of this work, and it's critical in ensuring sustainability and a safer and more effective response to domestic abuse. It's here where violence reduction units are key, bringing together different organisations, including police, local authority, health, community leaders, to be able to better understand the root causes of serious violence, including domestic violence, in each locality is crucial. Next slide, please. So we're on a journey in NHS safeguarding with domestic abuse and violence, and we have an aspirational vision for the future. We want to create an inclusive NHS that responds sensitively to all victims and survivors of domestic abuse. We also need to better understand perpetrators and offenders in order to prevent abuse. We need place and space data on all forms of domestic abuse to better understand scale and prevalence. And we also need the lived experience voice to underpin that data, turn the numbers into a meaningful narrative for change. So trauma-informed practice, seeing what's happened to someone rather than what's wrong with someone, contextual safeguarding, understanding that abuse can happen outside of a home environment, and a strengths-based approach that empowers a person to change will be key to this work. And this is where programs of work like Pathfinder will be incredibly beneficial. Our strategic priority for NHS England is to assure that all NHS providers have a domestic abuse and violence policy for their patients and staff, that these policies should profile access to independent domestic violence advisors and independent sexual violence advisors for victims and survivors. And we need to have appropriate referrals and systems in place for perpetrators and offenders, should that be an issue too. We're creating a tackling serious violence blueprint in NHS safeguarding, where integrated care systems and violence reduction units will work together on the same trauma-informed priorities, including domestic abuse and violence. We want this blueprint to be multi-agency whole system, and it can then be shared across other integrated care systems in England, in the hope to be able to reduce unwarranted variation in the response to tackling serious violence and domestic abuse. Next slide, please. So NHS Safeguarding have created our own social movement with an adaptive narrative that's been designed to challenge people's perceptions on safeguarding and child protection. So to follow the work that we're doing, you can join us on Twitter. We have an NHS Safeguarding hashtag, and during the public health emergency, we've created a hashtag called COVID Safeguarding, and it's got over 3.4 million reach. And to find out more about our NHS safeguarding work streams, you can join our future NHS community of practice. So any professional that's working in the realm of safeguarding can join. And if you're interested, please email me or the england.safeguarding@nhs.net mailbox. I'll pop that in the Q&A for everybody. And if you've got a mobile phone, please open your camera or your QR code reader if you're on Android, and hold it over the screen on the little NHS Safeguarding app tool QR code, and that will enable you to download the new version of our NHS Safeguarding app. Next slide, please. So what can we do after today? We are going to hear such powerful, impactful, and challenging and exciting moments and statements from everybody today, and we need to actively listen, believe what we're being told, and do something with information that we've been given today. We need to be curious. We need to ask the questions, whether it's with colleagues, patients, family members. Do you feel safe? Is there anything upsetting you at home? Is there anything you're too scared to talk about? We need to avoid re-traumatizing by using trauma-informed approaches. And we need to find pragmatic solutions to enable safe disclosures of any form of abuse. And finally, create a social movement. We need to be brave and be bold. Let's shift the unseen, unheard, and untold to seen, heard, and spoken. Thank you.
Thank you so much, Bex. That was amazing. And I love how you closed that in terms of a social movement. You know, sometimes health gets put into the too hard box, and it absolutely shouldn't be. You know, it's a big system, but there is so much that you can do. And NHS England have really started to demonstrate that. So thank you so much for joining us and that.
You're very welcome.
Presentation.
Thank you.
All right. Okay. So my iPad's decided to turn off, so just bear with me 1 second. Next we have, how do I introduce this wonder? This is Miranda. She's the Programme Manager at Standing Together. I've had the pleasure of working with Miranda for years and years, way before I became the CEO of Standing Together, and I'm incredibly proud of the work she does, and she's an absolute asset to Standing Together. And yeah, I will pass over to you in terms of you feeding back. Lovely to see you. I'm going to turn off my camera this time because otherwise I'm just on the whole time. And it also means I can tweet. Anyone that's not tweeting, please tweet. Whole health is the hashtag. See you later, Amanda.
Thank you, Goody. Okay, so I'm going to start by saying that it's been a tremendous honour to be involved in this project and to work alongside experts from AVA, IMCAN, Safe Lives and RSI. When I was first brought into this project, to lead on this project, I felt both quite excited but also a little daunted to be working on such an ambitious and large-scale project looking at transforming health response to domestic abuse, but also acutely aware of the need. So I came from working within the domestic homicide review team, and I used to sit regularly on the Home Office DHR quality assurance panel, and what came up time and time again was the crucial role that health plays in responding earlier to domestic abuse and improving survivors' lives, and the countless missed opportunities that for health professionals to identify domestic abuse, ask the question, share information, and potentially prevent that homicide from happening in the first place. So currently in our health response to domestic abuse is fragmented. We have some pockets of good practice in mental health, some good practice in primary care and acute health, but all of this is disjointed. And what's really unique and unprecedented about Pathfinder is that it brings all of this good practice together in a single model response to domestic abuse, which covers the whole of the health economy. Next slide, please. So today, as part of my presentation, I don't have a lot of time, but I'm going to cover an overview of, I'm going to quickly talk about the project, cover the key objectives and the principles underpinning our work. I'm going to speak about our good practice whole health model and our key achievements as part of this project. I'm going to talk about the different elements of our toolkit, our publications and next steps. Next slide, please. Okay, so our Pathfinder project, is there a slide missing? Was there a slide before this one? Sorry. Feel like it's there we go. So I just wanted to quickly thank our funders, the Department for Digital Culture, Media and Sport and the Department of Health and Social Care for giving us the opportunity to do this work. It's been a huge privilege, as I said. And I'd also like to thank our consortium partners once again. Next slide, please. Okay, so the Pathfinder project is a 3-year pilot project which has covered 8 sites across England, and including 27 NHS trusts and CCGs. And amongst other things, it has funded 10 health-based IDVAs, 2 IRIS programs, which has covered 64 GP practices and 3 domestic abuse coordinators. Next slide, please. In terms of our key objectives, the project's objectives were to identify promising practice within health settings, to develop a model of good practice that could then be easily adopted by any NHS trust, and then disseminate this learning and good practice from this model. Next slide, please. So the following are the kind of key principles and values that have underpinned and framed the work of our project and have been embedded throughout our work, and they're really important. So our work has been survivor-led. It has, throughout the work that we've done with this project, it's been centered around the experiences and needs and asks of survivors. Ava and Imkan have led on staggered consultations with survivors, both at a local level at our Pathfinder sites, but also at a national level, focusing on protected characteristics, and have spoken and consulted with over 140 survivors. We take a gendered approach as part of this work, and which is an approach which recognises that domestic abuse is cause and consequence of women's inequality, and it frames domestic abuse within the wider agenda of violence against women and girls. We also take an intersectional approach throughout this work, which sort of is mindful and aware of the multiple barriers and layers that individuals will face when accessing services due to their intersecting identities and their experiences of discrimination. And we also promote trauma-informed practice as part of all of this work, which is a strengths-based approach which is grounded in understanding of the impact of trauma. Next slide, please. So this is our whole health model. We're very proud of it. This is the culmination of all of our work at sites. It brings together all elements of good practice, from acute health to primary care and mental health, into this single model response to domestic abuse and health. And what was really clear to us from our work at sites was that systemic, and as Rebecca reiterated earlier as well, is that systemic approach is needed in order for this work to be sustainable in the long term and for it to be effective. So a robust strategic framework, governance structures really set the foundation for then specialist interventions to run smoothly and work and be sustainable. And a critical piece in all of this is that coordination piece. So whether you have a coordinator role in place, whether it's a domestic abuse lead within your CCG or your NHS trust, those roles are really essential, because they will, for example, be supporting your health-based IDVA. They will be ensuring that your health staff are being upskilled regularly and consistently. They'll be updating your training packages, making sure that your policies are up to date, supporting data collection, that data collection is adequate, and so on. So they are really a critical piece there. And what we really want to stress is that an effective response to domestic abuse goes beyond standalone interventions, such as it's simply not enough to just be delivering training or to have a health-based IDVA, but what we need is a more comprehensive approach that's sustainable and that's embedded throughout your systems locally. So that does include having your governance structures and policies in place, and having a really robust strategic framework in place around this work. Next slide, please. Oh, and I meant to say, running as a thread across that model, you have those principles that I highlighted earlier, which are really essential. So you want to make sure that your systems are, well, first of all, are evidence-based, so they're gendered and understand what the cause of this issue is. You want to make sure that they're reaching everyone, all of your survivors, not just a section of them, so that they're intersectional, and that they are informed by the lived experiences and needs of survivors, and that they're promoting good practice, a trauma-informed practice. Okay, next slide. Okay, in terms of our key achievements, we've trained over 2,700 health professionals. We've set up and supported 9 domestic abuse champions networks. We've reviewed over 15 trust policies, domestic abuse policies. We've also reviewed training packages, 8 training packages for NHS trusts. And in terms of our legacy, we have supported the consolidation or setup of governance structures at each of these sites, and we know that they will continue past the life of this project. So next slide, please. And in terms of the survivors that we have reached as part of Pathfinder, we have reached over 630 survivors as part of Pathfinder. These survivors were referred from health settings into and have then gone on to engage with services, and the referral pathway that they were referred through was set up through the Pathfinder project. And what we found out through Pathfinder was that actually health-based support is more likely to identify survivors who would otherwise likely be missed by general services or community services. So our health-based IDVAs picked up a higher number of disabled LGBTQ+ and BME survivors and older survivors in comparison to our national average of survivors who would generally be picked up by your community IDVA. Next slide, please. So this is our toolkit, which essentially is a step-by-step guidance on how to implement this whole health model that we've been speaking about. Each chapter covers one of the components of this response, and it includes a set of recommendations for local authorities and CCGs to facilitate the implementation of this model. And as well as these recommendations, we also have included a set of practical templates and resources that will hopefully support your local areas in implementing this model. So there's for example, domestic abuse coordinator job description. We've got a business case for health IDVA provision, an IDVA service level agreement template, domestic abuse policy assessment checklist, domestic abuse policy template. We've got it includes practical briefings for health professionals on responding to BME, LGBT, disabled and older survivors. And it also includes an e-learning module for health-based IDVAs, which was developed by Safe Lives. Next slide, please. So as well as our toolkit, we're also going to be releasing our survivor consultation reports, which also includes a set of maps detailing survivors' journey through the health system. Now, these are useful resources that you could be using for your training and so on, and they also include costings for those journeys. So useful tools. We're also publishing a key findings report, which will have a sort of highlights of what we have found at our Pathfinder sites and what's been achieved. And you can expect to see the external evaluation, which is being led on by the University of Cardiff, which will be published in August, and piece of work focusing on data collection and information sharing, which is being developed by Bristol University. And you'll hear a little bit about both of those later on in the agenda. Next slide, please. Okay, so I wanted to end the presentation with an image that sort of sums it up really, and this image is quite helpful in that what we have found in a lot of our health areas is that often you'll have one or two individuals who will be really passionate and will be driving and leading on all of this work, but often what happens is that the system to support them is lacking. So really Pathfinder is about creating that system and about setting up that infrastructure to make this work effective and sustainable in the long term. So we, as Rebecca said earlier, we cannot expect our health professionals to respond to domestic abuse adequately unless we are providing support to them and they themselves feel supported in doing this work. So they need to know that they trust, the trust of the CCG they work in has domestic abuse as a key priority, and that that the services in place, the support in place for survivors is adequate. As Rebecca said, we can't forget that a huge proportion of NHS staff will be experiencing domestic abuse themselves. So it's important that they feel supported in all of this as well. So as I close, if I could ask you all if you could take one thing back from this presentation, I would ask you to download the toolkit, go back to your area and have a think about what governance structures are in place within your area. Do you have a domestic abuse policy? Do you have a coordinator or a lead who's doing some of this work? Do you have a health-based IDVA? Do you have a training? Do you have training in place for staff in your local area? We know that this work isn't easy, that it's hard, and it takes significant resources and time, and it takes perseverance, but it can be done, and we're here to help you. So do get in touch with us if you need any help with it. I'd also just like to take one moment to thank our 8 Pathfinder sites and our partners at each site for all of their tireless work in the past 3 years. And I'd like to say a special thanks to our capacity building team, Caitlin, Vanya, Rani, Emma, Ruth Atkinson, Lucy, Ruth O'Leary. We are so grateful for all that you have done. This project would not have been possible without all of you and without all of the expertise that you brought to the project. So just a big thank you to you too. So I think that's me. There's the next slide with my contact details.
Thank you so much, Miranda. I'm literally sat here beaming with pride, which people will be able to see. That was really fantastic, and you covered so much, and we're still to time, which is amazing.
Oh, brilliant. Okay.
So thank you so much. And I know that Vanya has busily in the background been sharing all the resources on the chat function, and people are tweeting everything, but thank you for all of your hard work, Miranda.
Yeah, it was difficult to fit everything in a 10-minute presentation. So I would encourage anyone who has questions or to just get in touch, or if you have any comments and thoughts, please do get in touch with me. I'd love that. Thank you.
You absolutely smashed it. So thank you. All right, so next we've got Rani, who has worked in violence against women and girls for over 27 years. I'm not going to say on the screen, although I said I was, because it's just otherwise it's a bit awkward. So I'm going to turn it off, but I'm going to hand over to you now. Thank you so much for being here and for being a partner of the project in terms of IMCAN. We've loved your contribution. I'm really looking forward to it.
Okay, thank you, Gudrun. Hi, everyone. Okay, so I'm at IMCAN. Oh, here we go. Yeah. So what does equality, diversity, and intersectionality have to do with it? So my name's Rani, as it says, and I'm at IMCAN. So IMCAN, who are we? We're a UK-based Black feminist organisation representing specialists led by and for Black and minority ethnic women affected by violence against women and girls. We have over 2 decades of experience of working around sexual violence, domestic violence, forced marriage, and honour-based violence. We work at a local, national, and international level, and in partnership with a range of organisations to provide policy and practice responses to BME women and girls. We provide strategic advocacy, monitoring, evaluation, research and training. And our membership and sustainability work with our members of 40 plus across England, Scotland and Wales. My role within Pathfinder was to lead on equality, diversity and intersectionality. And I focused on 3 key areas: BME, LGBTQ and disability. Next slide, Caitlin. God, it's really hot. Sorry about that. In a bit of a summer moment here. Whew. Okay, so why is equality, diversity and intersectionality important when responding to domestic abuse? As you can see, stats there. You can take a few minutes to have a look at those. So we believe that it is not possible to adequately address domestic abuse in health settings without first looking at your commitment to equality, diversity and inclusion at all levels within trusts. This is because we know that survivors from minority groups are less likely to be asked about domestic abuse, believed when they disclose abuse, or offered support to meet their individual needs. This is due to a range of reasons, including pervasive stereotyping about what a typical domestic abuse victim looks like. For example, white, working class, and heterosexual woman. Whether or not the service is accessible or past experience of racism, biphobia, homophobia, transphobia, ableism, or ageism can lead to lack of trust. So survivors fear they will not get sympathetic, supportive response and will face further discrimination. Until services are recognizing the signs of abuse and responding appropriately to diverse groups of women who access the trust services, they will continue to be underrepresented in specialist services and overrepresented in domestic homicides. This is likely to change, and this is unlikely to change until professionals receive adequate training around diversity issues, domestic abuse training that takes into account the experiences of women with intersecting identities and needs. As part of Pathfinder, we consulted with BME, LBT and disabled survivors to hear what they felt services could do to improve the response they received. Following their advice and noting good practice at our sites, we recommend 3 simple things you can do to start addressing these issues. Next slide, please. Okay, so our first recommendation, diversity accreditation. So if you want to take a few minutes just to read the slide there, and this is from one of the survivors that was involved in the consultation. Okay. Some survivors we spoke to highlighted that they often felt that the health professionals they spoke to didn't understand them, their experiences or their needs, as you can see by that quote on the screen. For survivors to feel comfortable to disclose the abuse that they experience, it is important that they feel supported and able to speak openly with the clinician and are believed and their experiences validated when they disclose. In order to achieve this, we recommend that all NHS services should undertake a range of diversity accreditations and schemes to promote high quality diversity and inclusion standards in the workplace and to better represent the needs of all patients and staff. The Pathfinder Toolkit, which Miranda referred to earlier, outlines some of the key accreditations we recommend, including Stonewall Diversity Champions Programme and the Disability Confidence Scheme. Next slide. Recommendation 2, diversity staff networks. I'll let you have a look at that. Okay. One of the key things that came up in our conversation with the survivors was the lack of diversity in the services they accessed. Seeing themselves represented in the staff of the service they attended can make a big difference to how comfortable survivors feel about sharing their experiences and how confident they feel that they will be believed, listened to, and understood. NHS services need to ensure they are promoting diversity in the workplace and encourage diverse groups of people to work for them. One way to recommend doing this is to set up staff networks for staff members to promote diversity. We feel that a minimum network should exist for staff who are Black, minority and ethnic, disabled or LGBT+. In order to do this successfully, it is vital that these groups have a buy-in from the executive board, which we saw at one of our Pathfinder sites at the University College London Hospital. In each of the staff networks has an executive supporter who is committed to championing and supporting the group at a board level and attending at least one meeting a year to understand the issues that are being raised, but also to have an action plan. And so it's integrate part of the NHS services that you deliver. Next slide. Okay, recommendation 3, independent translation services. So if you want to just have a few minutes to read that. Okay, so finally, one key ask came up throughout the consultation with the survivors. They felt it was vital that they have access to independent services for British Sign Language and other translation services in health settings. Some survivors had particular traumatic experience when trying to access support from their health service, including being turned away and asked to return with a friend who could translate for them, and being sent away with a number for a helpline that they could not physically access as a deaf person. It is really vital and important that independent translation services are used, especially when you are concerned that the patient may be experiencing abuse. You should never rely on partners, friends, or family members in this case, as this could increase the risk to the survivor or make it impossible for them to disclose if the person translating for them is perpetrating the abuse, or could share the information with the perpetrator. The overwhelming thing that Pathfinder has highlighted is how much better services work when they work together and lean on each other for experience. So consider reaching out to your local BME, disability, LGBT plus services and ask them for help, ask them for advice, invite them in to staff briefings, to deliver training, build the relationship to ensure that your staff are confident in knowing who the local services are and what they can offer patients will go a long way to improve the experiences and the safety of patients and survivors. Thank you.
Thank you so much, Rani. Oh, you've already turned yourself off. You've gone already. I'll let you stay. Feeling really hot. Want to get off as soon as possible. Thank you so much for that. It's really informative, and obviously, like you said, the importance of finding out what is in your local area and actually utilising the specialist services out there and the amount of expertise that exist in those services, and also to really support them locally because they're often very underfunded.
Yeah.
And they need all of the funding and support they can get to basically.
And it's a great joined up approach, you know, working locally with the groups that have that expertise, that have the knowledge and are delivering the services, and also survivors trust and have a long history of doing that work. So why reinvent it when it already exists?
Couldn't agree more. Thank you so much. You can turn your camera off now. Right, so next we're really pleased that we've got Michelle and Claire doing a bit of a double act. Earlier they couldn't unfortunately get their videos to work. I'm not sure if that's been fixed or not, but if not, we will just hear them during their presentation. They are both from the IRIS programme in Blackpool, which is one of our Pathfinder sites, and I for one am really excited to hear what they've got to say. So thank you very much for being with us, and I'll hand over to you.
Hello. Hi.
Yeah, you're on.
Okay. Hello, everyone. My name's Michelle Sheridan, and I am a safeguarding practitioner, nursing and midwifery background, and I've worked at Blackpool Teaching Hospitals for the last 31 years.
Yeah, my name's Claire Bennett, and I am the IRIS Advocate Educator for Blackpool, and I've got a 15-year history working in different domestic abuse settings across the town.
Have the next slide, please.
Okay, so here we are. We've got Blackpool, known for its landmarks, the Tower, the Pleasure Beach, the piers, the promenade, the illuminations, the famous Tower Ballroom, and of course the Blackpool Six of Rock. We attract about 18 million visitors each year to the town, and you know, on this picture there, it looks like a fantastic place to come. However, just take a step back, a few steps behind the promenade, and it's a very different story.
Next slide, please. So Blackpool's in the, if you didn't know, Blackpool is in the northwest of England. We have 165,000 residents. Normally, without, obviously we've got COVID at the moment, so we haven't got any visitors yet, but we normally have 18 million visitors each year. But Blackpool itself is very densely populated, as you can see on the map. It's only 7 by 3 miles wide. I was born and bred in Blackpool, as was Claire. When we meet victims in our jobs, we find that a lot of people say, I've come to live in Blackpool because I went here as a child on the holidays, but they only see the bright light side of it. They don't see the severe neglectful side. There's a lot of houses with multiple occupancy, which once were hotels, that now can have 6, 7, 8, 9 flats in them. Next slide, please.
Okay, so yeah, these are some clippings that we took from newspapers and some headlines about the sort of how deprived the town has become. And in 2019, it was published just to be one of the most deprived areas in the UK. We've got a very transient population, and it's among these we see the worst effects of deprivation. You know, it's not all negative, and Blackpool's very desirable holiday destination, and it brings in 1.4 billion in tourism to the town, so it's something we definitely need.
Next slide, please. So local statistics, I work on the safeguarding team at the hospital. We have to have MARAC at the moment twice a month. So there's 30 odd cases every 2 weeks, which is obviously all the prep that goes on with that for all the agencies. And April to September 2019, 16,000 police call-outs due to domestic abuse, which you can see, and violence against women was most commonly reported, more than other crime. So me and Claire at the moment are working alongside the police just because of COVID-19 as a domestic violence practitioners each, and we're going out to it's called a domestic violence car, and over half of the calls that police get in Blackpool are domestic abuse or crimes against women. I am also work within the safeguarding team as a children looked after practitioner, and we have more looked after children than any other local authority in the whole of England, considering it's such a small area. And we have 585 looked after children. We also look after the staff with our colleague Stacey, who's a health IDFA at Blackpool Teaching Hospitals, and we have 7,000 staff at this hospital, and which she's also kept very busy. We also have a health ISFA in the hospital, work with people that have been subject to sexual violence. Next slide, please.
Okay, so these figures kind of speak for themselves, really. They speak volumes for the need for multi-agency work, and obviously the Communication Child Safeguarding Practice Review just shows that the toxic trio is definitely there. What we find in Blackpool is 8 out of every 30 children in a class are living with domestic abuse at home, so it's quite shocking, really.
Next slide, please.
End of May 2019 is when Iris Blackpool began, and for those who don't know, who might be on this conference, it's a GP-based domestic violence and abuse training, support and referral programme. It ensures that primary care practitioners can respond effectively to domestic abuse and that specialist support is available. We've already touched on our backgrounds a little bit, haven't we, there? Okay.
Can we have the next slide, please? So we started the training last May and we're spreading the word. We met the practice managers, we developed publication materials including little cards and posters in surgeries, signed up 18 practices in total. There's only 20 practices in Blackpool. We delivered the training within 6 weeks of setting up. We have got 17 practices on board, but now we've actually got 18 and they're implementing Iris within their practices. It was quite fast paced and we had to really hit the ground running, but we did a really good job and we've had quite a lot of referrals. Can I have the next slide, please?
Yep, so we've been running for 1 year, just over 1 year now. 73% of surgeries received clinical 1 and 73% have received the admin, and up to date 325 staff have been trained in Blackpool. Feedback's been really positive about the training and practices have been really flexible about fitting us in. And obviously they are more than happy for us to go into the surgeries and give us rooms, and yeah, it's worked out really well.
Next slide, please. So what has worked for us, what's worked I think is being within the hospital setting, and my nursing and Claire's experience as well, because Claire's got links with Falco's Women's Aid, I've got links with the clinical side of things. We're both within the safeguarding team within the hospital, so we've got a net. Our email is nhs.net, which I think looks very good. Between us, we've got a very good geographical knowledge of Blackpool and the surrounding area. It's actually 46 years in total. And we also have access to medical systems, EMIS, which is, that says there. And Claire has visited other Iris sites when we first got going to see how they ran their scheme. Next slide, please.
Yeah, it's not all been plain sailing. People don't like change. Some people have said to us, we don't have domestic abuse here, not in our practice. With the struggle with people don't have time to fit us in, everybody's busy and they don't really get their times for their own training, never mind somebody else coming in. A lot of them have said that they do their own kind of safeguarding training within in-house on like an e-learning. And then we've got people who are kind of still reluctant to ask the question. One really positive is the year before Iris Blackpool arrived, Blackpool received 1 referral from a GP. So yeah, it's had a massive impact on the response really for the victim from the GP services.
Next slide, please. So we wanted to get 100% of practices signed up. Actually, Iris have said they don't even expect that. They were happy with what we've done. Keep raising awareness of the service, expand. We've got another person working with us who's ex-police. She does a few hours for us as well. And continue to provide safe, quick, effective support, and looking forward to hopefully getting some future funding. Next slide, please. That's it. And if we can't do questions, but that's the end of the presentation. Thank you.
Thank you so much, both of you. I know there's questions in the chat box, so if anyone's got anything, please go to there. Thank you so much. It's amazing to hear what you've been doing in Blackpool, and like all the training and all of the stuff that you're doing. Oh, I can see Caroline's popped up. Lovely to see your face, as if by magic. This is our speaker. She's the head of safeguarding Royal Devon and Exeter NHS Foundation Trust, and I'm just going to hand straight over to you because we're running a little bit over.
Yes, okay, thank you. Just wait for my presentation. So hello, my name is Caroline Holt and I'm the Head of Safeguarding at the Royal Devon and Exeter, and I'm here today to talk to you about the success of having a co-located IDVA within secondary care. Next slide, please. So the Royal Devon and Exeter has an acute hospital and adult community services, and we don't just cover Exeter, we also cover a wider patch across Mid and East Devon. Domestic abuse has been part of the work of the Trust for many years, and in 2011 the Domestic Abuse Operational Group was set up alongside our Safeguarding Adults and Safeguarding Children's Ops groups, and that has driven and monitored improvements with policies for staff, patients, and also for training and other action. Now, my predecessor said that using the statistics of domestic abuse has driven change and got people on board, particularly the senior members of the Trust. So we know that 1 in 4 women and 1 in 6 men are affected by this. And would the NHS ignore this? If this was cancer that was affecting a new type of cancer affecting 1 in 4 women, would it be better funded? Would it be resourced if it was a lung disease or a heart disease? And she used that, and that helped people in the health setting to get on board with this. And occasionally we still need to do that today. Next slide, please. So we had some good practice going on, and we learned a lot, but we knew we wanted to do more, and we applied to the Pathfinder project and to learn more, and we were successful and got a health IDVA funded for a year on site full time, and we've had her since April 2019, and her expertise has been absolutely brilliant. It really is the expertise, and she's been able to give an immediate response when concerns are urgent or very complex, and that's meant that we haven't been missing some of the opportunities that we did before. And she's been able to support training as well, and many other actions. Now, we do need consent for a health IDVA referral from the victim or survivor, but where we haven't got that consent, she's been able to support them directly from the sidelines without breach of confidentiality by saying, this is the situation, this is how I'd advise you to support it. And in many of those cases, consent has then been gained. Next slide, please. So the stats of the health IDVA speak for themselves. Now, some of those she has seen are patients, and as you can see, many of them are at high risk MARAC level, and also some staff. The victims' age range has been great, and the referrals have come from across the Trust, whether from a community member of staff about somebody in their own home, or ward, theatres, emergency department, maternity or clinics. It was surprising in the first 6 weeks, 50% of her referrals were for over 80s. And although those figures have reduced, a big part of her work was the older people. And luckily, our IDVA Jess has been trained as an older person's IDVA. And the health IDVA is on an honorary contract with us, but works from her original domestic abuse charity Splits, and they've been key to coming on board, supporting her, and we've learned a lot from them as well. Now, having one health IDVA and a big trust cannot manage all the domestic abuse cases alone. Obviously, sometimes she has had too many to manage on the one day, and obviously she has days off and out of hours. So you do need well-trained clinical staff and a safeguarding team behind that to continue to support those patients. Next slide, please. So this isn't just a patient issue, as others have referred to. We employ 9,200 staff. We worked out that it's likely that over 2,000 staff have been or are affected by domestic abuse. The impact on those staff is absolutely great, and on their children too. But it also does impact on their colleagues and on the trust. We have had staff who have gone off sick because they didn't want to come into work and show the bruises that they've got. We've had other staff who live with a controlling partner who've been prevented from coming to work. And we've had one member of staff who was locked in her home and another one who had her car keys taken away. Now, the impact on those staff and the victims and survivors of this is great, but it does also impact on the trust. We also employ perpetrators, and that can be very complex, and there is a lack of support available for them. There's not so much as for victims and survivors. Now, we have for many years done routine inquiry of our patients about domestic abuse, but we now ask all our staff about domestic abuse. We've worked with HR and occupation, got it in the HR policies. So we ask staff about domestic abuse on the return to work after sickness interviews, exit interviews, and as part of the performance review. And we've only been able to do that because we've got support from the health IDVA for those at any risk of domestic abuse. So even those who are at a lower risk, not just the high risk. Next slide, please. I just wanted to give you a couple of cases so that our IDVA's worked with. The nurse on the left has experienced significant emotional and physical abuse and also damage to the inside of her home from an ex-partner. She disclosed this and consented to a referral to the health IDVA, but then went off sick. 2 weeks later, I saw her at work and I asked her tentatively, "Are you okay to be back?" And she said, "I'm okay because I've got Jess now." That's our IDVA. It made a real difference to her, and she was able to return to some normal life. But it also obviously has made a difference to the trust because we've got that nurse back working with her expertise with our patients. Now, the lady on the right is one of the older victims, and she was an 86-year-old who last year came into hospital 3 times admitted with falls. She'd had various investigations and been working with the falls team. And it was on the 3rd admission that she disclosed that actually she hadn't fallen. It was her husband, who was 89. He had pushed and kicked her in her kitchen. And she had been suffering domestic abuse for over 50 years. She consented to a health IDVA referral and a safeguarding adult referral, and our health IDVA was able to see her in the hospital, work with health and social service professionals, and then visit her at home as well. It was very complex because her husband had health needs and needed to be rehoused, but that lady is now safe at home and she hasn't been having any more admissions. Next slide, please. So there are challenges with this because the more we ask of staff, of patients, the more trained we get staff to be curious. There is a capacity of an issue with the health IDVA and the rest of the safeguarding teams to meet that demand, but it's important to do that. But funding for health IDVA is a real battle. And we had it for a year, and we've been able to get temporary funding of our health IDVA till the end of September. But our trust is committed to this, passionate about domestic abuse, but it's still very difficult, and there are competing financial priorities. Next slide, please. So what should happen in the future? Well, the Domestic Abuse and Violence Bill, as others have said, there's very little in that regarding health, and it's so disappointing because this could improve patient safety and quality of life, but it could also, as I hope I've demonstrated, be cost saving for the NHS. The NHS England are doing a lot of work, and particularly their domestic abuse policy for staff, but there does need to be a stronger focus, in my opinion, on domestic abuse in the safeguarding framework. Our local Devon CCG now has a domestic abuse and sexual violence lead for 2 years to support the health response to domestic abuse in Devon. And is that a way to go with CCGs coming on board? Because we do need domestic abuse and health IDVAs to be a statutory requirement for all NHS trusts, so that everybody does this and it's not a postcode lottery. But alongside that, we do need to secure permanent funding for health IDVAs, because without it, we can't embed that domestic abuse into the core business of safeguarding in healthcare. Thank you very much.
Thank you so much, Caroline. That was so informative and bang on time as well. So I really appreciate that. Some of the stuff that's coming out on Twitter, so thanks very much. But in terms of the findings of like the over 80s and then your toolkit, you know, to do what you've managed to do in a year is just absolutely staggering. And I couldn't agree more. It's about the sustainable funding that we need to keep this amazing work going, because it just, the impact it has is incredible. So thank you so much for your contribution today. Really appreciate it. And it's nice to meet you.
Thank you.
Although virtually. Okay. So we've got 3 more speakers left to go, and we're doing pretty well. Next we've got, here she is, here she comes, Amy Davidson. Thank you so much for being here. She's the head of safeguarding for North Staffordshire Combined Healthcare NHS Trust. She started her career in 1998 as a health support worker. So obviously you've got loads to share, so I'm going to hand over to you. All right.
Thank you. So thank you for inviting me to speak with you today. I'm going to talk about the experiences of Pathfinder in a mental health trust. As Goody said, my name's Amy Davidson. I'm a mental health nurse by background, and I'm the head of safeguarding. And as part of that, I'm the domestic abuse lead for our trust. Next slide, please. So first of all, really thinking about why it was so important, one of the Pathfinder pilot sites. And North Staffordshire and Stoke-on-Trent has a population of approximately 470,000 people, so just under 500,000. It's a mixture of very rural farming communities and suburban and inner city areas. And the city of Stoke-on-Trent itself has some pockets of quite high deprivation levels. On average, across our locality, there are 45 cases of domestic abuse per 10,000 adult females in the area. So obviously on top of that, you've got the figures where there are male victims, the cases that we don't know about, and even that, the reported figures are slightly higher than national averages. There's also the argument that for many years now, there's been NICE guidance that supports the routine exploration of experiences of domestic abuse within mental health care services, and I still don't think that is embedded in clinical practice as widely as it should be. Also, in the 2.5 years I've been in post, I've seen that locally in the learning from domestic homicide reviews, there's often a recurrent theme around missed opportunities to either ask the question or what people did in terms of response to that question, that perhaps somebody was giving clues and those weren't picked up on by staff. So normally it's a fear of, it's not an unwillingness to explore the issue, it's a fear of not knowing what to do if they get a positive disclosure. So also that kind of evidence, there's lots of opportunity within the pilot to support developing staff skills and confidence within mental health services. Next slide, please. So what we did is, I know it's been touched on earlier, the domestic abuse policy part of the toolkit. We used the draft version of that and reviewed our domestic abuse policy within the trust against that in order to make sure that we were in line with that best practice. Having the pilot created a safe space for those honest, open discussions and that kind of critical challenge and a review of our current policy and practice, both on a strategic level and with our frontline staff, to enable them to talk openly about the barriers they felt in their practice, whether that was time constraints, the ability to signpost people appropriately, not knowing where to go for specialist support and advice. Alongside that, the challenges that have been referred to in earlier presentations around sustaining funding for specialist workers, around those competing clinical priorities. So we established the role of domestic abuse champions within the trust. We felt this was really important in order for there being only one point of specialist advice, to kind of spread that across the organisation and embed it in everyday practice, rather than it being seen as, oh, that's something that's done by the safeguarding team somewhere else. We looked across our services and decided to focus on the front door services. And this was literally because we thought that was the best way, with a limited amount of resource, to capture the most number of people who were coming through our services. We used a train the trainer model, and that again was part of our thinking about sustainability after the pilot had ended. Our volunteers as DA champions, which we had lots of, it was really, really good response. Had 2 days training from our local specialist domestic abuse agency, GLOW, who I can't thank enough for their support throughout this project. They then went on to deliver co-facilitated training packages around domestic abuse awareness for all of our staff, with the idea that once the domestic abuse champions had delivered it co-facilitated with GLOW, then they would be able to deliver it in pairs together across our organisation, and that we would have then a body of trainers who were able to go out and deliver domestic abuse awareness training. We also established a domestic abuse forum that meets quarterly, obviously at the moment virtually. And this is about giving our champions an opportunity to have peer supervision. Both myself as head of safeguarding and our senior safeguarding nurse both attend that forum as well to provide support. And also our plan is, as we go forward, is to build in an educational slot to that in order to keep the domestic abuse champions up to date with specialist training. We were looking at bringing in training from a variety of different specialist agencies. We've also been able to enhance our learning opportunities and training opportunities for staff across the organisation. We already had domestic abuse embedded in our level 3, both child and adult safeguarding training, in terms of asking the question and what to do when you receive a disclosure. But this has enabled us to add an e-learning package that's available for all staff, which enables people perhaps to access information in a way that's certainly at the moment more accessible to them, and gives them the ability to go back and revisit that at times when they may come across cases in the clinical practice. Next slide, please. The challenges that came, and I think this is kind of a heads up for anybody who's thinking of trying to implement change in their organisation, from the how we did it, was really, it's establishing that, and I can't emphasise enough, that meaningful commitment from across the organisation, from strategic board members right down to frontline practitioners, their line managers, in terms of supporting them for release from their day job to attend training and meetings and the forum. And that recognising that that commitment is going to be needed from across your organisation. There will be a commitment needed from human resources, there will be a commitment needed from IT services, say from many different clinical teams, but that actually it's really, really worthwhile and will bring across that positive change right across the organisation. A big challenge for us was recognising our IT limitations. in terms of being able to gather, as you all know, when you're going for business cases for funding, and people love facts and figures, and our IT limitations in terms of what we recorded about patient interventions and the timescales it takes to change IT systems, particularly within the NHS, meant that we weren't able to get all the things in place in terms of gathering data that we wanted within the timescale, and that's kind of an ongoing piece of work. Recognising that if you possibly can, it's a really good idea to get a project lead in place at the beginning of any sort of big project of change, because there will be competing priorities. As a colleague of mine says, it's the loudest bird in the nest is the one that gets fed. And I think this is very, very true within NHS organisations. There will be competing priorities both from within the integrated safeguarding agenda and across the wider organisation. So it's about being really, really dogged at times with the reasons why this is such an important change. And that's where it comes in really useful to look at the underpinning evidence, looking at things like the Pathfinder Toolkit, the NICE guidance, the why we must do this, and then looking at in terms of service user stories and these, and you can't fail to be moved by the impact that a badly handled response to disclosures or not asking the right questions of people has upon people when they're accessing mental health services. And it's also about establishing sustainability for after the change project has finished, and ensuring that there is ways of carrying on that learning and that it disappear with the end of the pilot scheme. Next slide, please. The benefits for our organisation were we firmly seem to be establishing domestic abuse as a health issue. As Caroline said in the previous presentation, 1 in 4 women are affected by this and 1 in 4 men, and that's the people we know about. So it is a health issue. Linking research and practice together, the University of Birmingham has completed a piece of research recently that looked at, particularly in terms of more long-term and significant mental health problems in terms of psychosis-related illnesses, bipolar diagnosis, that actually there's really strong links started to emerge between people's experiences of domestic abuse and then them going on in later life to develop those types of illnesses. It's increased the awareness much broader than the champions. We've noticed we're getting lots more calls from staff relating to either people's experiences of domestic abuse or that they've identified in their work with families that the impact upon children in the family. It's embedded routine questioning regarding experiences. We had already put as part of our initial assessment the routine questioning regarding domestic abuse, but I think the Pathfinder pilot has really, really helped to embed that questioning and improve frontline staff's understanding and confidence around asking that question. It's improved our governance and policy and the support systems around responses to domestic abuse disclosures. It's increased our referrals to specialist support services locally and to MARAC services, and that's also included for us referrals to perpetrator services. For instance, on the back of the Pathfinder pilot, our liaison and diversion service that works within police custody has developed a pathway for people who are in police custody as a result of being arrested for perpetrating domestic abuse. So then that we have that pathway to guide them to specialist support if that's what they're willing to engage with. And ultimately, I think you would hope this is all over has improved the experience for people accessing our services, which is the whole reason really for anybody to be working within an NHS trust service. Next slide, please.
Just so you know, we've only got 15 minutes left and 2 more speakers, so just wanted to give a bit of a guide because you won't know that.
Developing and moving forwards then, we're looking at developing domestic abuse champions in our inpatient areas, how we look at developing the champion's role in areas of our business where patients may have specific vulnerabilities, such as our neuropsychiatry services, learning disability services, looking at how we further develop our carer support for our staff, and also we look at improving that data gathering and being able to audit and review services. Next slide, please. And just at the end, that's my contact details if anyone has any questions or wants to get in touch afterwards.
Thanks so much, Amy. I'm sorry, I didn't know how many slides you had left, so I just thought I'd interject because I don't want to eat into their time. That was amazing. Thank you so much for all that insight. So the next person we've got speaking is, I'm going to say, I know him as GJ, but Professor GJ. And I could listen to this man for hours, and sometimes he blows my mind with some of the things he says. So no further ado, I'm handing over to you. We've got 15 minutes left.
That's very kind. I promise I will talk extra fast. Thank you so much for that very kind introduction, Goody. My name is GJ Melendez-Torres, and I've been leading the independent evaluation of Health Pathfinder. So today we're just going to share some very headline, very early findings from the evaluation, with the promise that we'll have a lot more to say about a lot of the other aspects of Pathfinder at the conclusion of the project. Next slide. So the goal of our evaluation was really to do two things. The first thing we wanted to find out was, what did Pathfinder achieve in terms of strengthening links between inquiry, disclosure, and referral in the settings in which Pathfinder was implemented. And to do that, we analyzed national data from Merix and Insights to understand how referral and uptake patterns changed in areas where Pathfinder was implemented. The second thing we did, and this is really where the rich data came from, was that we wanted to find out how Pathfinder worked and what it was like to implement it. And so to do that, we spoke with 28 professionals and 20 survivors who had directly engaged with Pathfinder through their lives or through their experiences. Next slide. So the headline finding here, and I think this is a really impressive figure, is that in police force areas where Pathfinder was implemented, there was a 10% increase in the rate of cases discussed by Merix in each quarter after implementation. What this tells us is that Pathfinder contributed to improved identification of high-risk cases. And we saw that this finding was fairly robust, for example, to excluding different areas from the analysis. So what this means is that as a headline finding, and we obviously have a lot more work to do to understand this, but as a headline finding, Pathfinder was able to contribute to the improved identification of the highest risk cases. And we saw that in terms of the cases that were going through Merix in police force areas where Pathfinder was implemented. Next slide. So there are three particular highlights I want to share with you from our extensive interviews with professionals and survivors. And those three highlights relate to the ability of Pathfinder to generate expertise, Pathfinder's work in co-creating safety between professionals and between professionals and survivors, and the role of Pathfinder in really opening up possibilities, new possibilities and new opportunities for innovation and action, both at the individual level, but also at the systemic level where Pathfinder was implemented. Next slide. So this was one of the things that came out of our consultation, which is that Pathfinder is a very complex intervention. It's a very complex model with a lot of moving parts that work in different ways in different places. So this was kind of the complexity we were trying to wrap our heads around when we did our interviews with survivors and with professionals. Next slide. Now, one of the most interesting, and to our mind, one of the most important and inspirational things about Pathfinder was that professionals and survivors alike noted that Pathfinder generated expertise in several ways. It generated improved knowledge on the part of professionals. It generated improved confidence in making that inquiry and supporting that disclosure. And it also generated expertise in terms of advocacy for survivors as well. Professionals pointed out that one of the things that the Pathfinder did was that it helped them feel less, quote, clumsy, for example, about how to do a particular inquiry. And survivors pointed out, for example, that they didn't start this conversation about how are you feeling, how's your partner and stuff. I probably wouldn't say anything. So one of the most universal aspects of Pathfinder was that it did a lot to lift up expertise where it was implemented, both in terms of individuals, but also in terms of system responses to domestic abuse. Okay, next slide, please. The second highlight that I wanted to share with you was this idea of co-creating safety. And what this does is that it really speaks to the ability of Pathfinder to give people the space, time, and ability to link those alliances between professionals and survivors, and between professionals in different areas to co-create safety. We chose the phrase co-creating safety because we think it really speaks to the fact that Pathfinder wasn't necessarily an intervention that was imposed. Rather, what it did was it facilitated different kinds of links and different kinds of alliances that allow people to come together to imagine what an optimal response would look like. To make that really concrete, one of our survivors that we interviewed spoke about it was the doctor who actually put me in touch with the IDVA. And as much as I'm grateful for her doing that, I honestly felt I couldn't have sat with my doctor and explained some of the stuff which I felt I'd been able to do. And a professional said as well, the main difference is having a qualified worker accessible to that support where needed, because I do believe that a window of opportunity opened. That idea of co-creating safety was so inextricably linked to this idea of those windows of opportunity, taking advantage of those windows of opportunity, not just between professionals and survivors, but also between professionals as well. This takes us on to our third point, which is on the next slide, please, which is the fact that Pathfinder opened up new possibilities in terms of individuals, but also in terms of innovation and impact. One of the things that I think is most well known about Pathfinder is that a very important part of it was co-locating services. And where Pathfinder involved co-locating those services, for example, putting it in mental health practices, Pathfinder had a really essential role to play in creating space and time for inquiry, disclosure, and referral. It's about making that space and making that time to allow for that inquiry to happen in an optimal way. But that's only a very small part of it. In reality, one of the things about Pathfinder that I think is hard to pin down, but that is really so central to why it was successful, was its impact on a systemic level, on a coordination level, at a trust level, at a CCG level, at an organizational level. Where Pathfinder involved strategy, innovation, and coordination, it created new links and conversations around domestic abuse. We have a really meaningful quote here from the survivor who speaks about how the doctor rang her and said, we've had this lady in and she does this, this, and this, and I think, you know, you'd be really well to go and see her. And one of the things about Pathfinder is that it was responsible for that link being able to come into existence. But again, that systemic level is so important. And professionals, for example, spoke about how Pathfinder inspired them to set up new communities of practice, new networks, new ways of thinking about how to respond to domestic abuse effectively within their trusts, within their CCGs, within their organizations as well. Next slide, please. So we still have a ways to go in our analysis, and it's still rapidly developing, and we're doing the best we can to make sense of the vast amounts of data that were shared with us. But for the time being, we really do want to share our sincerest thanks to the site leads and the consortium partners for sharing their time and expertise, to the IDVAs and advocate educators who did so much to help us recruit survivors, to the professionals who took time out of their schedules to share their insights with us, and finally, and always and again, the survivors who took so much time and so much energy to share their experiences with us. Their stories really are the reason we do this work, and we're extremely and always and again grateful to them for all of their time and insight and their experiences in sharing their journeys with us. So thanks very much. Please stay tuned because we'll have a lot more to say about the evaluation as we progress, and I'm sure we'll take any questions in the chat as they come.
Thanks, GJ. That is fantastic. Rather than me doing the closing remarks, I'm literally going to say this and then I'm going to hand over to Sandy. I just wanted to say thanks to all the speakers and everyone that's attended. We're still up to sort of 255, which is amazing. Thank you for staying with us and hearing about all of this. Obviously, we're all really keen to promote kind of the whole health model, and I would just like to echo what Miranda said. If there's one thing you do after today is to download the toolkit. I'm not going to come on after this. I'm going to hand over to Sandy because obviously at 12 we will probably cut off. So over to you, Sandy.
Hi, thanks so much. I'll try to talk quickly. So I've been leading an offshoot of the main Pathfinder initiative, and it's a project identifying best practice around how information about domestic violence and abuse is and should be recorded and shared in the health service. Two key aims of the work are to form a national consensus on recording domestic violence in medical records in different healthcare settings. So I focused on emergency medicine, maternity, general practice, and mental health, and to form a national consensus on best practice in relation to sharing DVA information into and out of healthcare and within the healthcare service. So the key output will be guidance on recording and sharing. And there are three contexts in which recording and sharing domestic violence information might happen. So for direct patient care, for an internal audit or for regulation by the CQC, or for local authorities, the sort of space and place data that Bex mentioned, and then for national data sets like the hospital episode statistics, which help hospitals to sort of recoup payment for the care provided, and also that those databases are used for research. So in the work that I've been leading, I focus mainly on sharing for direct patient care, although there will be some recommendations for audit. And I don't know if Teresa Kirpax is still on the call, but we've had a chat, and I'll be sharing my findings with the CQC to see where they might have a role. So as others have said, domestic homicide reviews and other types of reviews often cite inadequate information sharing as a factor, and they also often mention poor recording. And several healthcare specialties are implicated: GP, emergency, mental health, and these are the clinicians that the recommendations will target along with maternity. As some context, the guidance will primarily support health professionals to record information about disclosures of DVA, and so disclosures where the person's said that they're a victim or a perpetrator. And to a lesser extent, it will support healthcare professionals record risk factors such that health professionals are more likely to inquire about DVA in the future. And the guidance will support health professionals to share information when the patient has given consent for sharing, but as well as in cases where they haven't given consent or when they've explicitly withheld consent. It will support health professionals to share information within the health service, to share information with other services and agencies, and to record information they receive from within the service and from other services. And it will apply to cases that fall within and outside of formal adult safeguarding processes. So the safeguarding processes that apply to adults at risk. I've used multiple methods to do this work and to draft some recommendations. Policy analysis of guidance documents from national bodies and professional groups such as the Royal Colleges, an analysis of domestic homicide reviews, reviews of academic literature and discussions with key stakeholders. And from the research, I've produced some draft recommendations, which I'll be finalising using a consensus process with a team of experts. So I'll just share some of the findings from the research. On recording information, we found that very few guidelines for professional groups mention recording domestic violence information at all. Almost none say what data points are important to record and which ones should be prioritised given the time constraints of a consultation. Almost none say where to document domestic violence, and only 2 guidelines mention anything at all about documenting information about perpetrators. Several domestic homicide reviews have cited poor record keeping, so this is all really relevant, the fact that guidelines don't mention documenting. In most cases in the DHRs though, the clinician didn't know about the DVA, rather their poor record keeping of risk factors might have led to missed opportunities to inquire, which we've heard about a lot so far. When there is a disclosure, the difficulty lies in knowing how to record that information safely, especially because patients can access their GP record online and perpetrators might coerce access to victims' records or see domestic violence recorded in their children's records. GP guidance asks that GPs use redaction and the hide from online access functions for DV information, but this relies on the practice having a reliable redaction policy and the GP remembering to use the hide from online access function. So these aren't fail-safe options. GP records are also increasingly enabling a wider range of health professionals to access the record, and the same is true of hospital records. These are now increasingly available to, trust-wide clinicians, or all hospitals use sort of interfaces where patients have access and other clinicians have access. So this means we need to think about how best to record domestic violence information. Sharing information and making it available to other health professionals, it can be really beneficial so that other health professionals are aware of the risk. But an untrained health professional might use that information inappropriately. Interestingly, there's no guidance about whether and how health professionals and systems should hide sensitive data from other health professionals. So this is something we'll be discussing in the consensus meeting and forming some guidelines on. And then specific to sharing information, professional groups guidelines all mention which agencies and services outside of healthcare health professionals should consider sharing information with. But otherwise, the guidance is really patchy, especially on sharing information within the health service. And this is really important because in DHRs, most cases that implicate health were about inadequate sharing between, for example, GPs, health visitors, emergency department, mental health professionals. And notably, most of the cases in DHRs are about inadequate sharing about the perpetrator. But as I've said, guidelines are especially patchy when it comes to perpetrators. So my final report, as Miranda said earlier, will be available in August. So we'll finalise the guidelines using the consensus process and then send the report to the Royal Colleges for approval. And I'll be able to, through the Pathfinder Consortium, be able to share it with you all. And yeah, I'm looking forward to seeing what you think about it.
Thank you so much, Sandy. That's great. We've literally run 2 minutes over. If the panelists want to say goodbye, maybe put your cameras on and we can all say goodbye to everyone. Thank you so much, Miranda, Caitlin, everyone for your contribution. I hope everyone that's still here got a lot out of that. And like we said, the one thing we'd love you to do is download the toolkit, please. So goodbye from all of us. And thank you so much. Take care, everyone. Bye.
Thanks. Bye.
Bye.